Thank you and good morning. Let's get this going. This is my bio, and here are my disclosures. So what we're going to go over in the next few minutes is we'll review the diagnosis and assessment of a patient with COPD, and we'll highlight current treatment strategies, primarily focusing on stable COPD. So here's the outline of what we'll go over. So we'll start with COPD definition and pathophysiology. So this is the definition from GOLD, the Global Initiative for Obstructive Lung Disease. And you see the URL on the bottom of the page, and it's really a wealth of information that's updated every year about COPD. And just to highlight their definition, they define COPD as a heterogeneous lung condition with chronic symptoms characterized by abnormalities of the airways and/or alveoli, and we'll go through that in a minute, leading to airflow obstruction. So in that definition, there are multiple pathologies that can lead to this abnormal airflow obstruction or this abnormal spirometry that we see here on the left. And just as a reminder, this on the top right corner is a normal lung histology. So the airway here, if you can see my pointer, with the fine alveolar attachment surrounding it and a blood vessel next to it. Emphysema, we have loss of the alveoli and collapse of that airway in the middle. Mucus metaplasia, so seeing this mucus stained in red in this, completely occluding this airway. And then small airway disease, we see primarily epithelial inflammation, much thicker interior to this airway, without much smooth muscle hypertrophy, in contrast to asthma. So how do those three pathologies lead to airflow limitation? So normally we have our airway held open by the elastin fibers in the alveoli. Whoops, sorry. We've lost those alveolar attachments from emphysema, and then the mucosal inflammation and small airway fibrosis, as well as mucus hypersecretion, all lead to obstruction of the airways and expiratory airflow limitation. So on to the assessment of COPD patients. So these are the signs and symptoms of COPD, the cardinal signs and symptoms shown in red: cough, sputum, and dyspnea. But as you're well aware, these are fairly nonspecific, and many respiratory diseases present this way. Wheeze is not specific for asthma or COPD, can be seen in both. And then some of these other symptoms, and specifically the physical exam findings, may only be seen in more severe disease, so generally not so helpful in the initial diagnosis and assessment of COPD patients. Because of that, it's led to the development of several questionnaires that patients can fill out that are a more subjective or objective categorization of their symptoms that you can follow. So on the left is the COPD assessment test, or the CAT test, series of 8 questions that we score 0 to 5. Patients will fill out their symptoms of cough, phlegm, chest tightness, etc. And you just simply add up the numbers. So for a maximum score would be 40. We consider 10 or more to be symptomatic and 20 or more to be highly symptomatic. And then even simpler on the right side is the modified MRC dyspnea scale, a series of 5 questions highlighting activities that lead to dyspnea, with 0 being normal or breathless only with strenuous exercise. And the most severe at 4 is people who are too breathless to leave the house or get short of breath while dressing. And we consider an MMRC score of 2 to be symptomatic dyspnea. So people who have to walk slower than people their own age, so husband walking slower than their wife or vice versa, or people who have to stop when for shortness of breath when they're walking at their own pace. So having to stop is not normal, it's not aging, that's a sign of disease. So then on to spirometry, and spirometry is still essential for the diagnosis of COPD. And GOLD years ago had tried to simplify things using a fixed ratio of FEV1 to FVC less than 0.7 to define airflow obstruction, and then categorizing mild, moderate, severe, and very severe based on these somewhat arbitrary cutoffs of FEV1. You may see these in older literature, but they really don't play into current treatment guidelines right now, but some pulmonary function tests will still report these GOLD categories. And just for a reminder, GOLD is based on post-bronchodilator FEV1, so if that shows up on a board question, that is important to note, but I think in clinical practice, any spirometry is better than no spirometry. So then how do we assess the risk of exacerbation? So the best predictor is what happened in the past. So this is data from the ECLIPSE study, which followed over 2,000 COPD patients for 3 years. In this yellow color is patients who had no exacerbations in the first year. They were most likely to have no exacerbations in the second year and no exacerbations in the third year. Conversely, patients in the red color had 2 or more exacerbations in the first year, most likely to have 2 or more exacerbations in the second year and 2 or more exacerbations in the third year. The subjects in gray who had 1 exacerbation in the first year really had an almost equal chance of being in any of those categories in subsequent years. So we put all that information together, and GOLD uses this ABE assessment tool. This has been simplified. It used to be ABCD. So we just start on the left. We did the spirometry to confirm the diagnosis. Use that fixed ratio of FEV1, FVC less than 0.7. Using the FEV1 to grade the airflow obstruction. Again, not super important, but you may see that somewhere. And then really treatment is based on their risk of exacerbations and their symptoms. So that 2 or more exacerbations we consider high risk, and also added to that high risk category is patients who required hospitalization for even a single exacerbation makes them high risk, as opposed to the lower risk category. And then the symptomatic based on MMRC of 2 or CAT greater than 10, categorized as patients. If they're at low risk of exacerbations, it's just categorized by their symptoms, A or B, and everyone at high risk of exacerbations is put into this GOLD E category, which will have implications for their future treatment. So remember, every smoker with shortness of breath does not have COPD. There is a differential diagnosis, and most commonly it's asthma and other diagnoses we see on the left, bronchiectasis, interstitial lung disease, and congestive heart failure. So it does behoove you to do an evaluation, including spirometry, to confirm that diagnosis of COPD. On the right are other conditions that can lead to airflow obstruction and similar symptoms, and may likely depend on where your area of practice is, how common you'll see these conditions. So what about other testing besides pulmonary function tests? People often ask, should I get a CAT scan for every patient with COPD? And that would be a lot of CAT scans. Currently, it's not recommended as part of the standard guidelines, but could be used if there's questions about the differential diagnosis, specifically diseases like bronchiectasis, which you see in this CAT scan, in this slide in the upper lobes, or other patients who have symptoms that seem to be out of proportion to their lung function abnormalities. Obviously, chest CT scan has a role in lung cancer screening, and many of these patients, based on their smoking history, will fit that guideline. And then patients with more severe disease who were being referred for interventional therapies will also require a CAT scan. A complete blood count with differential is now part of the management of patients with COPD, especially those with frequent exacerbations, and we'll show how the blood eosinophil count contributes to the management decisions. And then all patients with COPD should be tested for alpha-1 antitrypsin deficiency. It's uncommon, but not that uncommon, accounting for 1% to 2% of COPD in the United States, and it is treatable. The testing is initially an alpha-1 antitrypsin level, followed up by a genotype or protein phenotyping, and these can be done at many hospital or commercial laboratories. So remembering COPD is a systemic disease, and we need to assess for comorbidities. And all of these comorbidities shown in this slide are more common in people with COPD than similar smokers without COPD. We already talked about screening for lung cancer, but things like cardiovascular disease, osteoporosis are all important conditions to think about and assess with the way you would normally do so, but having a low index of suspicion to do this testing. So on to the treatment of stable COPD. So general overview to treatment of COPD, there's 2 goals. We want to reduce the patient's symptoms and reduce the risk of future events, exacerbations, decline, mortality, et cetera. First and foremost is smoking cessation for all current smokers, and that is really underappreciated even in our tertiary and quaternary referral center. Supplemental oxygen, we'll talk about more in future slides, as well as pulmonary rehabilitation, and ensuring that patients are up to date with their recommended vaccines, and I show that some common vaccines that we have to think about in these patients on this slide. So we've known for more than 40 years that supplemental oxygen reduces mortality in hypoxemic patients, and this is data from one of the two seminal trials, a NOT trial, came out in 1980. Again, patients with continuous oxygen, this was comparison with nocturnal oxygen, but we also know in comparison to no oxygen have improved survival. Entry criteria into this trial are shown at the bottom, and you will be familiar with those because that's how you certify patients for Medicare to get oxygen. So PaO2 less than 55 millimeters of mercury, or SAT of less than equal to 88%, or a PaO2 of less than equal to 60, or SAT less than equal to 89% with complications such as cor pulmonale, right heart failure, or polycythemia. Most commonly in the US, obviously, we're using oxygen saturation to make those determinations, and that can be either at rest, sleep, or exercise. Although the benefits for using supplemental oxygen purely in exercise-induced desaturations are not clear from a large study called the long-term oxygen treatment trial. But some patients may still gain a symptomatic benefit. So pulmonary rehab, we show on the right here what we call the vicious cycle of COPD. Patients get shorter breath, they do less, and then with being less active, they reduce their functional capacity, and that leads to more shortness of breath, and they get into this vicious cycle. And the goal of pulmonary rehab is to break this vicious cycle. And what is meant by pulmonary rehab, it's a multidisciplinary program with a medical director, and then run by either a nurse, a physical therapist, a respiratory therapist, or some combination of those. It's a 24-session, usually over 6 to 12 weeks, so averaging out to 2 to 3 times a week, and it is a Medicare-covered benefit for COPD if you make that diagnosis. It consists of exercise, lower body aerobic exercise, treadmill, bicycle, etc. Upper body exercise, in some places do respiratory muscle training as well. And there's a large educational component about what is COPD, how to use your inhalers, what to look out for. And then there's a very strong psychosocial component. These are patients who may have been homebound or being forced to get out of the house and see people who look just like them, who are wearing oxygen, and getting that support. And pulmonary rehab has really been shown to improve exercise capacity both in the real world and in laboratory testing, as well as improve many other outcomes, quality of life, and reduce risk of exacerbations. And it's likely underused. Obviously, there's a challenge of finding programs, and people have to go to it as well. So these are the medication algorithms from GOLD, and we'll go through some of the highlights in subsequent slides. Again, you see where the ABE rubric shows into the different medication treatments. Those with group A, the low symptoms, low risk, really you can treat with anything, any bronchodilator. The group B, the more symptomatic, dual bronchodilators with a long-acting beta agonist and a long-acting antimuscarinic are now currently recommended. And then for the group E, also the dual bronchodilators are recommended, and blood eosinophil counts now only come in for use of inhaled corticosteroids, and we'll go into some more details of that, but remembering that number of 300 cells per microliter, 300 eosinophils per microliter as the indication for inhaled corticosteroids. On your right, you'll see what to do if patients are failing the initial treatment, and they can fail in one of 2 different ways. One is due to dyspnea, the other is due to exacerbations. There's fewer things we can do for dyspnea, and often involves changing devices if people are not happy with a dry powder or a meter dose inhaler, for example. Exacerbations, again, using the blood eosinophil threshold, and if patients continue to fail, there becomes a lower eosinophil threshold for using inhaled corticosteroids. And then we'll talk in future slides about some of the other drugs that may be prescribed for the frequent exacerbator. So just to summarize some of the general principles, bronchodilators are always our first-line therapy, and we want to use long-acting bronchodilators. And in current recommendations, we're talking about dual bronchodilators, LAMA, LAMBA, in combination inhalers are preferred over using 2 single inhalers. In addition to giving a long-acting bronchodilator, we want to make sure that all patients have access to a short-acting bronchodilator, usually albuterol, to have for increased symptoms or to use prior to exercise or prior to their pulmonary rehabilitation. We want to target the use of inhaled corticosteroids, really focus on who we need to use that, again, targeted by the blood eosinophil count in the frequent exacerbators with the 300 or greater. And there are triple therapy inhalers that in single device contain all three drugs, which are preferred to using multiple devices. But remembering that there are side effects to inhaled corticosteroids, thrush, hoarse voice, and most concerning is an increased risk of pneumonia in these older patients who already have impaired lung function. So several oral therapies have been available for more than a decade to reduce exacerbation risk. First is roflumilast, is an oral PDE4 inhibitor, and this data shows that in patients treated with LABA-ICS, about a 20 to 25% reduction in exacerbation rate. The indication is in patients with severe COPD. The label says FEV1 less than 50% with chronic bronchitis, and most importantly, with that exacerbation history. GI side effects like nausea and diarrhea are extremely common on this drug, and people often get used to them, but it is something to warn your patients about. In the middle, you see data about using azithromycin, 250 milligrams daily from a large clinical trial. Again, a 27% reduction in exacerbation rate over a year. And this, in post-hoc analysis, was shown to be more effective in older patients, former smokers, and those with milder COPD. And the most concerning adverse effect here is hearing loss, which was generally reversible after stopping the drug, but it's something to be aware of, again, in this older group who are at risk for hearing loss. And then there was a database study from the Veterans Administration that compared the two drugs. You'll see roflumilast in the curve in solid, and the dotted line is in azithromycin, showing a reduced risk of exacerbations or worse outcomes on roflumilast compared to azithromycin, and that's now being studied in a randomized clinical trial. But in the last year plus, there have been 3 new therapies approved for COPD. First is ensifentrine, which is a nebulized drug. It's a PDE3 and 4 inhibitor, so some similar mechanism of action to roflumilast. It's both a bronchodilator and an anti-inflammatory. Showed bronchodilation in the clinical trials, but interestingly showed a reduction in exacerbations as well, though with the caveat patients in those clinical trials were not all necessarily treated with guideline-based therapy. In the middle is dupilumab, which may be familiar with from asthma. It's an injectable anti-IL-4, IL-13 inhibitor. And in patients with a history of exacerbations with that elevated blood eosinophil count more than 300, about a 30% reduction in exacerbations over 1 year in the seminal clinical trial. And then most recently approved is mepolizumab, another formerly a drug used in asthma, anti-IL-5 injectable therapy. Can be, again, similar exacerbation reduction as we see with dupilumab. This carries the indication for eosinophil count of greater than 150, and that's somewhat controversial. The most recent study used 300, but one of the older studies that went into their approval used a lower exacerbation threshold. So it remains to be seen what the differences may be. And again, patients with that frequent exacerbation history were enrolled in these studies. So what about other treatments, surgical or interventional treatments? Lung volume reduction surgery has been known to be beneficial for more than 20 years, and that's most beneficial in patients with upper lobe predominant emphysema, showing the requirement for getting a CAT scan to assess that, who have low exercise capacity. Surgical lung volume reduction has almost been completely supplanted by bronchoscopic approaches with one-way valves, and this is an example of one of the valves here. It's placed into the airways, and this is the larger airways and peripheral airways. Air can flow out, but not back in, leading to collapse of the lobe behind multiple valves, leading to lung volume reduction without surgery. And then lung transplantation is the other surgical therapy that can be considered in severe patients. And obviously, all of these should be, patients you're considering for any of these should be referred to an expert center. So we'll summarize and go into some review questions. So we talked about how COPD includes emphysema, large and small airway disease. It's a heterogeneous condition. If you take away one piece of information, that spirometry is really essential for the diagnosis, though we may be changing that description in future years' lectures. And then we assess patients with this multidimensional assessment, looking at symptoms, airflow limitation based on spirometry, their exacerbation risk based on their history of exacerbations, and then their comorbidities that we would expect to see in patients who are older with smokers, but are all more common in COPD patients. In terms of treatments, thinking about what I call the tried and true treatments or the non-pharmacological treatments, smoking cessation, although obviously that involves pharmacotherapy, supplemental oxygen and pulmonary rehab, which is likely underutilized. There are some online options and virtual options are being studied, so I think getting your patients to exercise is really quite important to this. And then pharmacotherapy, really bronchodilators first, and using dual bronchodilators, combined inhalers with LAMA and LABA, reserving inhaled corticosteroids for an add-on in triple combination inhalers in the setting of the elevated blood eosinophil counts in patients with high exacerbation risk. So a very targeted approach. In the past, we'd said we only had azithromycin or roflumilast to use for patients with frequent exacerbations, and that's a decision based on the side effect profile, which one you may want to use. But now we have several newer therapies in our armamentarium. Ensifentrine nebulized therapy does not require a blood eosinophil threshold, and then dupilumab and mepolizumab in patients with eosinophilic COPD with a risk of exacerbations may be of substantial benefit. So we'll go on to some cases, and I think you have a response system for this. Is that correct? Do they have an audience response for this? Okay. So a 65-year-old male, current smoker, presents with cough and exertional dyspnea, MMRC score of 2. He had 1 exacerbation last year. You do spirometry, his FEV1 is 55% of predicted. FEV1 over FVC is 0.6. Appropriate treatments include A LABA-LAMA combined inhaler, B, triple therapy, that's a LABA-LAMA ICS, C, nicotine replacement therapy, D, all of the above, and E, A, and C only. So we'll give people a few minutes to respond to that. All right, well, you don't see your results, but more than 80% of you got the right answer, and that's C, A and C only. So why is that the case? If we go back to our ABE assessment tool, patient had FEV1, FVC ratio of less than 0.6, so he's confirmed to have COPD. FEV1 is 55%, putting him in that gold 2. Again, not really important for that treatment part, but only had 1 exacerbation last year, so low exacerbation risk, but symptomatic based on the MMRC score of 2, so short of breath, having to stop walking at their own pace or walking slower of their peers, puts them in that gold group B. Treatment for gold group B, bronchodilators or first-line therapy, and that preferred is the LAMA-LABA combination inhaler. Remember, we're reserving the inhaled corticosteroids for those with frequent exacerbations, so group E with elevated blood eosinophil counts. And he was a current smoker, so smoking cessation first and foremost in his treatment, and then remembering to do our usual assessment of comorbidities, heart disease, lung cancer screening, diabetes, et cetera. So on to our next question. You see a 70-year-old woman in follow-up after hospital admission for COPD exacerbation. She has daily cough and sputum. She has to stop walking after a few minutes on flat ground. She uses continuous supplemental oxygen at 2 liters per minute. She was treated with antibiotics for bronchitis 6 months ago. You order spirometry, and her FEV1 is 45% predicted. Which of the following is her strongest risk factor for a future exacerbation? Oh, can we put back the response? Okay, there it is. A is chronic bronchitis symptoms. B, FEV1 less than 50%. C, 2 or more exacerbations in the past year. D, use of supplemental oxygen. Or E, her MMRC score of 2 or more. So we'll give you a moment to answer that. So more than 90% of you have the right answer, and that's C, history of 2 or more exacerbations in the past year. So, looking at her history, she had that hospital admission, that's obvious, but then she had this bronchitis that needed antibiotics. So does that meet our definition of exacerbation? So how do we define an exacerbation? It's sort of retrospective by how people were treated. So treatment with antibiotics and or systemic corticosteroids for a chest illness. So people may say, I had a bad cold and I needed antibiotics. So that's considered an exacerbation. A bronchitis, they may not use the word exacerbation. What are the risk factors? It's obviously more severe airflow obstruction. Current smokers are at higher risk. People with symptoms such as chronic bronchitis are at higher risk. Gastroesophageal reflux disease puts patients at higher risk. Elevated white blood cell count, a high risk for future exacerbations, and we already talked about elevated blood eosinophil count being a risk for future exacerbations that may be treatable. And again, the people with high risk, 2 or more in the past year, or 1 or more hospitalizations. So that is our main judge on the highest risk, and that's how we would treat that patient. So I will stop with that, and here's some references for you. Thank you.